You've already learned the most important thing. Don't ever follow Dr. Fooster. I'm not going to be nearly as exciting as he was. And so now I just have to find the slideshow. Okay, so in a way my topic I could have done it in about 5 seconds. So it sort of says, what are our initiatives, future directions? So the answer to that question is really very simple. Given our financial reality, our new Institute Director, Gary Gibbons, has been on a listening tour, and he's gone to where many of you are. And of course, what he heard were two messages, which he resonated with. One was protect investigator-initiated research, and secondly, protect early-stage investigators. So systematically, we are going to devote our limited resources to those two goals. So we're probably not going to have very many new initiatives. Okay. I mean, if I give you there will be a few larger projects, and then will be a few initiatives, and we will try to pick those as widely as we can with of course, all of you helping us do that, and we're working on different ways to do that will really bring the extramural community in to make sure we're making the wisest choices with the limited funds we have. So I decided not to talk about that more than to say that, and then to move on to some other topics. And I don't know whether these will be interesting or provocative to the group, but when I saw vaccination as one of the titles, I thought of the March of Dimes, because our goal really here is to follow really the March of Dimes. So I don't know how many of you know that the March of Dimes was started in the 1930s. Of course, FDR had polio, and it was the idea of a march of dimes, literally dimes. We worry about that we only have $3 billion, but in those days they were worried about dimes. So people actually brought dimes to the White House, and there's Franklin Roosevelt counting those. So that was when I was just a glimmer in my parents' eyes. My father was still overseas. But when I was a child, of course, this happened. This is polio vaccination, and this eliminated this disease. Now, interesting in terms of what Dr. Fooster said, so we had the technology, we had the biology in 1954. And so now we roll ahead, and except for maybe in a few places like Syria and Pakistan, we have eliminated disease, but there is that huge human component, societal, behavioral component, even when you understand the biology before you actually get total prevention. But clearly your goal is to do this so that SHAPE will then have to take a new topic, like the March of Dimes did, which took birth defects, because polio was not going to be a way to collect very many dimes after this revolution. So you're trying to have a revolution similarly. So I thought what I would do is, from my perspective, is talk a little bit about where we are in that path. So this is some data from our ERIC study, and the line in red here is really the last 10 years. So if you look at first-time MI, if you look at death, and so first-time MI is close to primary prevention, you'll see that in the last decade, we've actually been reducing MI by about 5% per year. That's a pretty impressive success rate compared to the decade before, where it was more like 2 or 3. And a common theme is that this is happening in both whites and blacks. We're not eliminating the disparities, but we're the lines are going in parallel. Why are we doing this? Well, it's a combination. Most people who do the analysis, how much is prevention, how much is treatment, in terms of treatment post-MI, et cetera. Most people come up with, half and half. Those analyses are hard to do. They have a lot of assumptions. But clearly, at the population level, we are reducing traditional risk factors. That explains part of this. How much we don't know. But here is LDL levels in people between 60 and 70, 146 to 122. That's an impressive drop. You would think that that would result in a big drop in MI. Blood pressure, actually in the decade during the 90s, we actually had very little impact on blood pressure. It was stable at 141 among treated individuals. Since then, we've had a really pretty large effect. So we've had a decrease of 10 in the delta, which is what you'd like to see in a blood pressure study, in this decade. Is it leveling off now? We don't know, but it's an impressive drop. And one thing I'll point out about this is some guidelines say always be less than 140. If you want to be always less than 140, your mean blood pressure has to be 120. Blood pressure is variable. So, like Fuster showed those slides, so the question is, what's the average actually? Because the average probably explains the biology, not the variation. So anyway, in blood pressure and LDL, we've obviously had an impressive decade. So that's the good news. So CDC has this concept called avoidable deaths. And they've looked at the last decade, 2001 to 2010. And avoidable death means deaths, cardiovascular deaths in people less than 75. Again, this is undoubtedly a combination of primary, secondary prevention plus treatment. About a quarter of the CVD deaths in the United States occur in people under 75. It's about 200,000 a year. And about half of those occur in people under 65. So again, that's your target population. Now, this I think is very interesting data. So in this simple report from CDC, they divided it up by age groups. About 2,000 people die before the age of 35 with cardiovascular disease. However, when you look at these different, this is a 20-year group, 35 to 54, 55 to 64, 65 to 74. I hate to say it, this group here, we've done really well in this last decade. 37% reduction in death rate. Again, probably a combination of better treatment, prevention, treatment. This middle group here is down 27%. These are all statistically significant. I didn't test these versus this. But look at this. People between 35 and 54, 43,000 deaths in 2010. No difference, 6%. So whatever we're doing right here, we're not having impact here.
Are those numbers flipped for the middle one?
No, I don't think so.
The absolute numbers.
These are absolute numbers. Number of deaths, percentage decrease.
But it's,
Don't forget, the baby boomers are happening here.
I know,
These
but
are
61,000 to 65,000.
You don't have the denominator.
I don't have the denominator. Don't forget, there are more baby boomers here. This is the baby boomer generation. A lot more people here. Okay, these are not the denominators. But I wanted to show you the number because when you talk about why you're talking about prevention, the numbers. That there are 65,000 people in this age group in 2010 who died of CVD. But what's interesting, from a scientific point of view, are the differences in the rates. I don't think we know what's happening here. At least I don't. Is it obesity? Is it health disparities? What is it? I don't think we know. At least I don't know. I hope some of you know and you'll tell us. Okay, many of you probably know of Chris Murray's 8 Americas, the concept 2005, that if you divide up America in racial groups and geography, that you can find places where the death rate on cardiovascular disease is 8-fold different. So you can find places where the death rate by county is or geographic or census tracts is like in the worst place in the world, and some places where it's remarkably good. But actually, you don't have to do as sophisticated as analysis of that. So these are the same data on the avoidable deaths, so these are under 75. So Asian women are at 22 per 100,000. African American men are at 143, a seven-fold difference. So when you think about what strategies we need and who's high risk and who's not, we still have this great variation in our country. But what's interesting is if we look at the 10-year decline, it's pretty similar. So everyone in our society, now this isn't by age group, this is combined age groups, everyone under 75, are going down about the same percentage. So just to quote Chris Murray, he is arguing that we really need to focus on the young and middle age, again, a theme from the earlier talk. I mean, he is talking about blood pressure and cholesterol here. I don't know if that really is the main explanation for the diversities, because actually if you look like for African American men, in at least older African American men, they do have more hypertension, of course. They have higher disease rates from hypertension. But if you look at the control rates and the awareness, they're very similar. So disparities are a tough issue. I don't want to say they're easy. And of course, this is just a slide to show you, you've got to worry about individuals, families, organizations, etc. And under individuals, of course, we have genes, cells, and organs, and we've had a lot of great advances, but in a way they've only said things are more complicated in terms of understanding the biology. So that leaves us, not surprisingly, with this situation. We have a tremendous demand for clinical trials and other high-quality scientific evidence to drive policy, and we have this supply. So we have this battle in our society. Not battle, but we have this need for a greater supply. We have a high demand, and we have a supply. So we have another complication here, and this is I don't know if you can see this cartoon in the back. This woman lets in the Grim Reaper. Her husband is hiding behind the couch, and it says, "Getting warm, warmer." The challenge we have is because of our success, event rates are going down. So if you want the definitive answer, of course, trials and studies, whether they're trials or just observational studies, have to be bigger and bigger. And others demand a certain kind of evidence, not expert opinion, but rates are going down. That's really challenging, and funds are either flat or declining. I don't have a solution by those three factors at work. But let's think about, some glimmers of hope that won't completely solve this problem, but are what people are thinking about as ways of addressing this. And the other thing is the challenge of the falling rates in terms of primary prevention. And actually, I think the third thing I would say is because of the increased focus on trial evidence, what we're discovering is how little we knew. So, for example, blood pressure, these are the European guidelines, came out a couple months ago for treating people who they call elderly. They never actually find elderly, but I think they mean between 65 and 80. So they're talking about, should we actually treat to 140? Currently in our country, the value of people who are being treated, NHANES, is probably about 135. If you went to Northern California Kaiser and looked in their data, it'd probably be 130. Well, what do the Europeans say? They call this a 2B, quality C. Just highlighting the fact that even in an area like hypertension, which people thought, oh my God, we know everything we should know, there is a data gap with this kind of situation. Now they point out that if you're elderly and your blood pressure, and you start off with a blood pressure above 160, which right now is very few people are going to be running around with 160 because most people are being treated, then the quality is class 1A. So we have this evidence gap. You've wrestled with that. Sounds like the life of your organization. You can look at lipids too. This is the guideline that will be presented on Wednesday and was released last week. And they point out we need RCTs to evaluate statin treatment for adults over 75. How many of you treat currently adults over 75 with statins if they haven't yet had a CVD event? How many don't? So, another evidence gap. You've identified a lot. And so we have this huge problem. Okay, so one solution is more funds. And then there's this issue of disruptive technology, not some of the technologies you've been talking about, but other technologies. You've heard the word big data. And can we make trials more efficient? And so I'd like to just briefly talk about that. And to the people who've been doing this kind of science for a while, they're kind of concerned about whether this is rocking the boat, whether these new kinds of scientific endeavors are really worthwhile. As I was thinking about some of the things that people were talking about here, is with some of these approaches, if you already have, I was going to ask Dan, how many CT angios are done in America each year?
About 1 million, I think.
Okay, so let's talk about this study and think about that. 1 million people get currently CT angio. Okay, so this is a study from the New England Journal called The Comparative Effectiveness of Revascularization Strategies. What's important, what they did here is something that 5 years ago would not have been possible, but is possible today. So they took the ACC PCI registry, they hooked it to the surgery registry, and the new development is, without knowing IDs, but knowing when someone had an event, if it occurred in the hospital, you could match with Medicaid data. You don't have any personal identifying information. You could match with over 95% accuracy. Just knowing where the hospitalization occurred, what day it occurred, and then looking in these 3 data sets. So when you do that, and then you can build a model based on the data you have from these 3 sources of data, claims data, the 2 registries, whether someone had a high odds of having a PCI, who had the PCIs, who had the surgery, and of course, you kind of focus for these people in the middle, who based on your prediction model would have had an equal chance of having one or the other. Of course, they only had one. They didn't have both. It's not a randomized study. And the results here of this analysis show that surgery is better at 2 years. Surgery is not better at 30 days. Obviously, some people die. But if you survive your 30 days and get out to 2 years, now this is a study, I can't remember how many, it was like 300,000 or 400,000 people. But now you could look at people with COPD, you could look at people over, between 65 and 75. You could look at a lot of different subgroups because the sample was so large. So as we have more electronic medical records, as those records get better, as we're able to look at medical records from multiple systems, some of you may have heard of something called Blue Button Plus. So Blue Button Plus is the idea that every electronic health record system in America, within 2 years, should have the ability that the patient can press a button and get a download of a standardized set of data from their medical electronic record. They could then give that to SHAPE. You know, and if they had a CT angio, you could look to see what happened. And they could download their record to you and give it to you every 2 or 3 years. And one of the things that PCORI is funding is patient-led networks, in which patients, to the patients, you know, to the Americans, get a list, get 100,000 people who say, I will join SHAPE. And I agree that I will give you, you know, that I will download my medical electronic records every 2 years. So, this is interesting technology. PCORI, you probably know that PCORI has $500 million a year to invest in research. They're patient-oriented. So, that's one disruptive technology. A second disruptive technology is to embed trials in registries.
Can you tell us more about PCORI, because I heard some people.
It's kind of private, public. It's outside the federal government, has a big board of directors with some people from pharma, some people from NIH, some payers, et cetera, are on there. And they're focused on comparative effectiveness research. But they're also focused on the questions that patients are really interested in. There's a lot of patient input into their priority setting, and there's a lot of, actually, on the review panels, there are patients and patient advocates there.
Patient-centered outcomes research.
Research, thank you. PCORI, PCORI. But let's move on. This will be my last point. So another disruptive technology is to embed clinical trials within registries. So this is one that was published in the New England Journal involving the aspiration of thrombus from people who've had MIs. It was a large-scale trial carried out at remarkably low cost because it was already built on a high-quality registry. This was in Scandinavia, where such registries exist. I'll skip that slide and just give you the results of this study. So the top is really their primary outcome measure, and they found that if you remove the thrombus immediately post-MI, it really had no impact. But the point is that this trial of, I can't remember how many thousands of people, was done for under an R01, under a 500K R01, and done fairly rapidly. What I think is interesting for those who are interested in trials is, so all of the people here were actually randomized between these two approaches. These were the people who were not randomized, and they're both fairly large groups. There's about 3,000 in each of the two arms that were randomized and about 5,000 who were not. One thing that's interesting is the death rate for the people who were not randomized is 10%. So just one of the things that's very true about trials is they have great internal validity if they're done well. But their external validity, how they apply to the real world, that's always an issue. So even here, in a trial that was done in a registry, really a large trial, a lot of support, a lot, decisions were made not to put people in the trial. These people are obviously very different than the people who went in the trial. So with that, I'll end by saying we don't have very many initiatives, but we do have a new initiative out on the street this week called the Low-Cost, Pragmatic, Patient-Centered Randomized Control Intervention Trials. Basically, we would like to encourage people to use some of these new disruptive technologies to try to do trials more inexpensively. and in a variety of areas. This covers all of the areas that our institute supports. Some of the other institutes in NIH are supportive of this. And you know, I think slowly things are happening that will make trials and observational studies easier to do. For example, electronic consenting, where you can consent on the web, etc. So with that, I think I would like to thank a few people who contributed to this presentation. And that's it. Thank you very much.